Thank you for joining us for the UCA COVID-19, the role of urgent care in a pandemic webinar. We have a panel of urgent care clinicians who are here today to answer some of the most important questions we've been hearing about in the past few weeks. Our moderator today is Dr. Robert Rohatch. Dr. Rohatch is a senior executive with an extensive background in disruptive innovation in ambulatory medicine. In 2008, he co-founded Physician One Urgent Care, the physician-owned urgent care practice in Connecticut, to be certified and accredited, the first physician-owned urgent care practice in Connecticut to be certified and accredited by both the Joint Commission and the Urgent Care Association. Under Dr. Rohatch's leadership as the CEO, Physician One expanded to become one of the largest providers of urgent care services in Connecticut. In 2015, Dr. Rohatch was recruited to become a managing director of Merchant Medicine, a boutique consulting firm, working with large health systems and private urgent care operators to craft their on-demand strategy and build consumer-centric platforms. For the past 3 years, Dr. Rohatch served as CEO for Banner Urgent Care and Occupational Health Services, as well as Employer Solutions. Dr. Rohatch currently serves as an advisor to Solve Health. Our panelists today include Dr. Jasmeet Bogle. Dr. Bogle has served as the president of the College of Urgent Care Medicine since 2017. As a clinician, he is serving as the regional medical director and medical director for patient experience for MedStar Urgent Care. He is currently serving as an editor for the Journal of Urgent Care Medicine. Jasmeet has previously served as medical director for urgent care at Lancaster General Health System in Lancaster, Pennsylvania, and medical director for Virtua Health System Urgent Care and Occupational Medicine Network in South Jersey. Jeannie Kinkari, Dr. Jeannie Kinkari is Chief Medical Officer and co-founder of Physician One Urgent Care. Physician One was established in 2008 as a privately owned full-service urgent care center in Connecticut. Since then, Physician One has expanded to 23 locations in Connecticut, New York, and Massachusetts. Dr. Kinkari provides guidance and leadership to the organization's 100+ clinical providers. In addition to her work with Physician One, Dr. Kinkari is also an assistant clinical instructor of medicine at Yale School of Medicine, where she teaches medical students patient-centered medical interview techniques, how to deliver bad news, and other sensitive issues. Lastly, Dr. Sean McNeely is currently medical director for a large hospital systems urgent care network. As a board-certified family physician, he has worked in urgent care in some capacity since obtaining his medical license in 1997. Dr. McNeely is the immediate past president of UCA. He is also founding board member of the Board of Certification of Urgent Care Medicine, a founding board member and immediate past president of the Urgent Care College of Physicians, currently known as the College of Urgent Care Medicine, and sits on the editorial board of the Journal of Urgent Care Medicine. And he has also authored several chapters in the textbook of urgent care medicine. So as you can see, we've got a great panel of experts, during this time to handle some of the questions. I just have a few housekeeping announcements. You will receive a recording of this webinar tomorrow. It will also be posted on UCA's COVID-19 page. And then also just wanted to address that we're not going to be addressing the questions in the chat box during this webinar, but we'll probably use those to respond to your questions throughout, as we're going through this pandemic. So now I am going to go ahead and turn this webinar over to Dr. Robert Rohatch.
Good morning or good afternoon, I suppose, depending on where you are in the country. I think we're all sharing similar concerns from an industry perspective. What's going on in our healthcare system right now? How do urgent care centers and on-demand platforms play a role in what's happening? And what are the concerns that are facing our industry? And then over the period of this hour, we'll drill down and actually get into some clinic level operations that perhaps address or remove some of the friction in how we're going to change our business to be relevant in the future. So with that, why don't we go to the next slide, and we'll jump right in here. You know, over the past several weeks, I mean, everyone's been asked to sort of remain home and quarantine themselves as best they can. And the idea there is to kind of flatten out the curve, preserve our healthcare assets today for the folks that need it, so our system's not overwhelmed. I think what that's caused, and maybe it was a unintended consequence, but what it's caused is a fair amount of a reduction in volumes that we've seen in urgent care. So Jasmeet, why don't we start with you? What kind of volume reductions have you guys seen in your health system run platform in the Northeast?
Sure. Hi, good morning or good afternoon, everyone. Thank you for the question, Rob. Yeah, I think we have definitely seen a reduction in the volumes, barring the regular decrease that one would start expecting, as the flu season, goes away and the spring and summer come along. I would say our reduction would be somewhere around 20%. Because of the whole, stay at home and, quarantine measures that have been put in place.
Sean, what are you seeing in your area?
I think we're seeing about the same. We had a very, very busy flu season until just a few weeks ago, and suddenly our volumes dropped off. I've also noticed that others who I've spoken with have seen the same type of 20 to 30 to even 50, 60% changes. In conversations with ACEP, which we've been talking with about at the UCA level and the college levels in order to see if we can partner, they're also seeing these type of drop-offs in the emergency room. So it's not just us, it's all over the place.
So you think maybe these reductions are more of a kind of a reflection of the calm before the storm or active preparation for what's to come, as opposed to a lack of need of urgent care services today?
I think that's true. I think people are staying at home as they're told to do. I think that many of the things we see in urgent care aren't emergent, so people don't have to come in emergently. But I think at some point the door is going to open and the floodgates are going to let loose. So I know us and others are preparing for that event as well.
Gotcha. Hey, Jeannie, I've noticed, some operators have actually closed their doors entirely, and or choosing not to advertise or not participate in the testing process for the coronavirus. What do you think? Should urgent care centers be playing a role in the flow of this as emergency departments and hospital beds continue to fill up?
Hi, Rob. Thanks for that question. For us, the volumes have declined as well, and as folks have mentioned, I think that's certainly a reflection of the stay in place orders and stay at home orders. And I think people are afraid to come into urgent cares because they feel they're going to get sick. But as Sean mentioned, I believe people are going to get sick. They're going to need attention. And our role and responsibility has always been as urgent care operators to relieve the pressure on the emergency room, as well as the primary care providers. So we are seeing in our area, we're located in the Northeast, Connecticut, New York, and Massachusetts. We're certainly seeing other operators close their doors because they can't manage COVID patients. They don't have the protective equipment to keep themselves and their staff safe. And so they're closing their doors, and I expect, that we will be seeing some of that overflow. And we're also starting to see some hospitals, just a report came out last night. Many of the Boston area hospitals, which is in our neighborhood, have had a lot of healthcare workers that are testing positive. They're feeling that they are about to see a strain on the system. It's coming their way, and I believe urgent care is the answer and the solution to that. So I think we need to figure out a way to stay in the game and help keep the ERs from getting overwhelmed with the worried well, with the folks that are kind of this mid acuity, which is perfectly suited for urgent care.
Yeah, some really, really good salient points. So we can go to the next slide, Carla. I think it's a really great segue, into this sort of next series of questions. Jeannie, let's stay with you. In your market, have you, you're a private operator that doesn't have an affiliation necessarily with all the local hospitals in your markets. Have you reached out to the local hospitals where your urgent care centers are to try to understand, what are the micro market needs, and how does your platform play a role specifically, locally in helping these hospitals sort of disimpact their ERs, work with them on patient transfer protocols? How might you be able to retain O2 dependent patients within your clinics as opposed to admitting them? Have you discussed with these hospitals any of these kind of strategies?
So we have a partnership relationship with a couple of hospitals, big systems in our area. And, as this crisis hit and became evident, we did reach out and we said, look, we're your partner, we're in the community, we've got the skill set, we've got the bandwidth, we'd like to help. And unfortunately, I think the hospitals, from my experience, were a little bit slower to respond locally, and had their own kind of fire drills that they had to put out. And so we haven't, I think we have the support of the hospitals to, yes, go for it, but not really partnering in a meaningful way. I don't think they're as nimble. They're not as quick to be able to make rapid changes to their service lines, and certainly much slower than we've been able to respond. And so we haven't seen a great partnership evolve, but we're certainly staying in touch with them. We've been involved in their emergency preparedness calls to ensure that they don't forget we're here, and that when things, get to the point where they're ready to start using us as one of their resources, they will.
Great. Hey, Jasmeet, in your neck of the woods, you're with the health system, but have private operators of urgent care platforms reached out to your health system to say, how can we help? How can we integrate into your urgent care platform a little bit in terms of, being part of this health system's approach or response to this pandemic?
As far as I know, we have not had any such requests as of yet. If they're happening at a much higher level, then that's a different thing. But as far as I know, we have not had any such requests. And even being within the hospital system, I can tell you that when all this began, like Jeannie said, that even the hospital system itself, the inpatient side, the emergency room side was not, there was some confusion of what patients to transfer, how to transfer, and what not. We've been working closely with the Department of Health as well in the states that we are, and it's been a learning curve and work in progress. But eventually, we have kind of started to come into a zone where we are collaborating much better. Like I said, even within the hospital system. So forget about other urgent care centers. Even within the same system, it's been quite some work to get to that level. And just to add on to that, we actually have been working within the College of Urgent Care Medicine and UCA. We are currently working with ACEP to come out with some risk stratification and triage guidelines for urgent care centers which are out there, in order to help them make a decision whether the patient can be safely sent home versus do they really need to be in the ED. So that's coming down the line as well, and I'm pretty sure Sean's going to talk a little more about that as well.
Yeah, and I wonder if one of the outputs of one of the results of this pandemic is that the urgent care industry in general is better prepared in the future by working with local and state health officials to understand what the assets are and how they can be delivered in these kind of pandemics. At the end of the day, a 20 clinic platform is equivalent to a 120 bed hospital in the sense of staffing, beds, supply of the ability to deliver oxygen, medications, and the sort. So in my opinion, local officials need to understand that these assets are out there. Instead of counting just hospital beds, we should probably understand what the urgent care platforms look like as an adjunct as well. Sean, any additional comments to close out this topic?
Sure. As the years have gone on, the Urgent Care Association and the College of Urgent Care Medicine has been suggesting that urgent cares who are not affiliated to a hospital or a hospital system start working with their local hospital systems and health departments, so that they can be part of the response to emergencies like this. We haven't had one quite like this, but we've had some minor ones along the way. And I think it's important that we do that. Obviously, it's a little late now to start the conversations in the sense of they should have been started sooner, but we can still be part of the response. We should still be part of the response. And it's a great way for us to be integrated into the system. One of the biggest things that people complain about urgent care systems is that they're not part of the healthcare system. They're not part of the patient's home for where they normally get their care. But we've worked greatly to be part of that. We've integrated into many systems nationally. I think the same thing with our relationships with AAFP and ASAP. We're working once again to add to those, to strengthen those at these times where disasters occur or pandemics occur and they need help, and we need help, and we need to make sure that we're sending the right people to them and we're not sending the people who aren't going to get anything changed. Unfortunately, it's a little late to be doing all these things. Not too late, but it would have been great if we could do it sooner. But we definitely need to be taking advantage of this situation. Not that we want to find something good and bad, but I guess you do. And one of those good things is that we can start to have these conversations and integrate the healthcare systems that people are getting. Because like you said, urgent cares can do significant things, and if pushed, they can do even more. So while we're in the middle of this, we should be doing the best we can to help take care of our communities, because there will be a surge. We see it coming in the next few weeks, and depending on where you're at and how are we part of that. And then after the surge happens and things sort of go back to normal and people start going to their primary care doctors, all those well visits that they're going to do are going to get in the way of them being able to do the 6 visits that they normally do, or injury visits. So once again, we should be ready to do those.
Great. That's great insight into that important topic. Let's flip to the next question, Carla. It's kind of a great segue into, so at the end of the day, I mean, this is more of an industry-wide sort of question still, but do you think what we're going through is this an inflection point in our business? In other words, do you think when all the dust settles that urgent care looks a little bit different than it looked before this? We know some businesses, simply are not going to survive this, and those industries may not be part of the future in this country. I don't think that's the case in urgent care medicine at all, but I don't think it's going to look exactly the same either. What are your thoughts on this, Jasmeet?
Yeah, I'll put it this way: we better be different, otherwise, what's the point? What's the learning? What's the learning that we get out of this huge pandemic? So yes, I do think that people are going to realize that urgent care is a critical part of the healthcare continuum in this country. I think the urgent care owners, the clinicians, everyone will hopefully realize that we have a much bigger role to play. We are not quite there yet, but at the same time, we have a huge opportunity to improve and to actually make a difference. Urgent care centers really should be the frontline, places to go in these situations, because we realistically do want to keep the quote unquote healthy patients away from the unhealthy patients, and especially in this scenario, because it's a workflow issue, it's a supply chain issue, it's so many things combined together, along with the clinical aspect of this, that people who are already severely sick should not be near people who are not so sick, and vice versa. So yeah, absolutely, I think there's going to be a huge learning opportunity here for us in urgent care.
Yeah, Jeannie, how do you think about this topic in terms of our business maybe looking a little bit different in the future?
I definitely think this is an opportunity for medicine in general. I think that we should look at this opportunity as one that can reshape how we're viewed by the government, by our local communities, and we should leverage that. Make sure that we're part of the solution here. As we've already discussed, be a point for patients to access care when they acutely need the care, so that we're not overloading the resources of an emergency room or the hospital that are designed to take care of much more acute patients that have a lot more consistent need. And I think that, this is telemedicine's big break, not just in urgent care. I'm seeing telemedicine, kind of be the solution for a lot of this volume issue and how to care for patients without having to be in the same room and exposed to the same air that they're breathing. And telemedicine has a huge place in the urgent care industry as well as in the rest of the medical community. So I think there's that piece of it, which is certainly going to provide an opportunity to change what we look like as an urgent care industry. And I think that folks really need to look at, how do we keep ourselves fresh and relevant as things change in medicine. So I certainly think that this crisis has created that inflection point for all of us, and that's where how we should be thinking.
Yeah, it makes a ton of sense. Sean, any final thoughts to close this out?
I would echo the others. Definitely, we're going to see some changes. The first change is there's going to be some struggle for those that are smaller entities that are going to have to get through these volume numbers. Normally, the summers are low volumes, and we're already starting that. Secondly, I think the mentioned by Jasmeet that we're going to be looking at the way we protect our patients differently. Considering whether we should have well and sick waiting rooms, whether we should be dividing our clinics up in different ways, how we should prepare moving forward, what kind of PPE should we have, even if we're not using it regularly, where we are in the industry as to different, how do we relate to hospitals, how do we relate to different groups, all of that's going to change. And I don't know what all the answers are going to be, but I expect that we will be different. And I applaud Jasmeet's statement that if we don't learn anything, then it becomes another negative from this situation. We should definitely be moving on and becoming better.
Great points. Carla, let's move on. It's a good segue into the next slide. So appreciate the softball, Sean, but let's talk about patient volume. So we've had these reports of clinics actually closing their doors, starting to change how they think about staffing. And this is all being caused by a major dip in cash flow. As we all know, urgent care medicine is very cash flow dependent. It's a game of nickels and dimes, and smaller operators are going to find it very difficult to wait this out if they don't have a lot of money kind of in the bank. What kind of strategies can you guys suggest? I mean, I think between the four of us, we've all been at the point where we were, running smaller assets and sort of knew how tight money can be. But what kind of strategies have you guys yourselves employed or heard of others rolling out to help, sort of bide us time, for lack of a better term, during this process financially? Jeannie, why don't we start with you?
Sure. I mean, I think the name of the game here is when the revenue declines, which it does because of a decrease in volume, you have to look at opportunities to decrease the overhead. So I think smaller operators need to look at whatever opportunities there are to do that, including decreasing their operating hours so that they don't have to pay their staff for, pay out these resources if they're not seeing the volume of patients to support it. So decreasing their hours, considering things like temporary furloughs, talking to their landlords to speak about deferring payments for rent. We all suspect that this is a temporary decline in volume, and that as the curve goes up and patients begin to get sick and start to need the care, we're going to start to see the volumes increase. And in fact, those volumes may be even higher than our peaks in flu season. So if that is the expected trend, a lot of this stuff is deferment. And, the government is offering loans for small businesses. So looking into opportunities to access those loans, which are eventually, the plan is for those to be forgivable. So those are great opportunities for small operators to tap into. The challenge is that, you know, for these smaller operators, their resources to make these decisions, which require a lot of thought and input from a employment law perspective, HR perspective, all of those things need to be considered and carefully managed so that you don't end up in some legal trouble later from a labor perspective as well.
Yeah, so my understanding is part of this $2 trillion bailout package, there's a $249 billion piece of that. And I'll probably get the name wrong, but I think it's called the Paycheck Protection Act or Paycheck Protection Program or something along those lines, but it's a program administered through the SBA, and it's designed to keep small businesses afloat during this time. And my understanding of the program is they'll loan you a certain percentage of your payroll expenses plus an additional padding on top of that. It's a low interest loan that's deferred, I believe, for 6 months. But if you retain your employees past a certain period of time, I believe those loans, to your point, Jeannie, become erased and become grants, essentially. So, Sean, have you heard about whether or not, I saw some email traffic on the UCA listserv that urgent care centers might not meet the criteria for these small businesses? Is that true, or what do we know about that as of today? Sean, you might be on mute there. All right, Jasmine, we'll flip to you here. Maybe a little technical difficulties, but Jasmine, have you heard anything about this SBA administered program and whether or not we think urgent care centers will be eligible to apply?
I think it's a pretty complicated, document that came out, and we're learning as we go. Definitely, there has been some discussion about the fact that urgent cares might not qualify. I think, at least from our end, we can take this back and actually, provide more detailed information on our listserv and also as a follow-up to this webinar, because I think it's a pretty complicated to go through.
Yeah, I agree, but I think it's very critical to our members, especially the smaller operators. What is included in this package is retail businesses. And so I think, quite clearly we can make the argument, at the DC level that, we're in the retail business and so ought to be included if there's no other argument that we can make. That one certainly sticks.
Yeah.
Any other comments from the panel on this particular question? I thought Jeannie did a great job of outlining sort of some things to think about, ranging from, expense control around landlord rent abatement, federal and state aid you can apply for, staffing models, those kind of things. Any other suggestions from the panel?
This is Sean. Can you hear me now?
Yeah, hi, Sean.
Great. Sorry, I had a microphone problem. So I would turn this question on its head. I would think of this a little differently. We have an opportunity where our volumes are going to be lower, and we know that there's an opportunity for our volumes to be higher, to have almost like another flu season as things come in. So I would start to retool, rethink, and help out my team as much as I can, those that we can keep employed, and be ready for the next, urgent care 2.0, 3.0, 5.0, whatever we're really at, so that when there is great opportunity, that we're able to take advantage of it. Urgent care has always been a hurry up and wait type of phenomenon. Our winters are usually busier than our summers, and often we retool in the summer to get to where we need to be for the next year. It's very possible that summer could be busy and this could be our slow season. So I would recommend people think about how we can become better while we're kind of sitting and waiting for people at home to come see us.
So you're saying it's more than just trying to gain some expense control here. It's really around what you're left with when you're done with those activities. How do you supercharge or sort of juice those assets so that when the other shoe drops, which we know is going to happen, and it's going to get very, very busy, that we're ready to operate perhaps under different conditions so we can be more efficient and really take advantage of this disruption in our business. Is kind of that what you're saying, Sean?
Sure, and look at other opportunities like how does telemedicine fit in? Will it, what will it do in a few years or a few months? What other things could I be doing that don't have that aren't sick care? Should I be dividing my care into sick and well care? Should I be looking at occupational medicine, and how do I keep the occupational medicine from the ill patients? All these type of questions that we don't have great answers to at this point. Now is the time, although I know we're struggling to get answers to all the problems that are happening right now, but now is also an opportunity to retool our team to start thinking about these things in different ways.
So you mentioned telemedicine. It's a good chance to flip to the next slide here. Telemedicine, often people will consider it to be a different product line or a bolt-on adjunct to primary urgent care practice. Prior to this pandemic, a lot of urgent care operators had gotten into the telemed business and had that set up as an option. And I think they were experiencing the same thing that large employers and health plans have experienced in the past, which was a decrease in uptake of utilization. So let's start with you, Sean. Were you guys using telemedicine prior to this? And if you were, have you seen increases in its utilization?
So telemedicine was always something on the back burner. I think both my system and UCA recommended that we had telemedicine, that it was available, that there was something we could do. But now that we're trying to see the patients without being within 6 feet of the patients to some extent, a fire has been lit. And I think that's a national fire. There's always been this problem with, do we get reimbursed for telemedicine? How do we get reimbursed? Is it fair and reasonable compared to what we would get if someone walked in the door and we did almost all the same things? And there's different technologies for telemedicine. I've done telemedicine where we actually had devices where we could look in a person's ear, we could listen to them, as long as the person took the device and put it in those different places. There were little portals that were in the pharmacies. I've done telemedicine where you're just talking on the phone, which is what we used to just call normal conversations with patients back 20 years ago. But everything in between. And so getting yourself a platform, being sure that you're available to do it. And how will telemedicine come out of this? I have no idea. This may be that one thing that makes telemedicine what it will be in the future, where people will realize that this is an important step and that we can do a lot via telemedicine. I know that there are many locations that do many different types of exams and deal with different problems that we wouldn't expect to be able to be done with telemedicine. And are we accepting of that? The biggest thing with telemedicine has always been, do you get reimbursed? Now that we're trying to have patients avoid each other, that's been pushed a little bit to the wayside, and how long that lasts, we'll have to see.
Yeah, excellent points. Jasmeet, do you have any further comments on this?
Yeah, no, I completely agree with what Sean said. I would just add that this pandemic will definitely bring to the front lines the discussion about telemedicine reimbursement. What was back on the back burner, what was, and oh, by the way, we have telemedicine, is now definitely, at least for the interim, looking as a mainstream opportunity in medicine. And I think anything that gets mainstream definitely gets the push to have more discussion around the money associated with it. So, and that might actually be a good thing, because for urgent care, because our telemedicine platform within our hospital system has just exploded since this entire thing started. And what that means is that we are kind of getting some experiences from that as well. And the biggest experience for me personally has been just looking at the way the platform works, has been that we can now better triage patients. There is never a situation where 100% of the patients were told to stay home, right? The question is, what were the patients that we clinicians deemed appropriate should stay home based on the telemedicine visit, and what were the patients that we said, no, you actually need to come to the urgent care, or in fact, you directly need to go to the emergency room right now, right? So I think that's kind of going to be an interesting role of how telemedicine is going to blend and maybe even morph along with urgent care. And I really do hope that the reimbursement fire is lit and it actually benefits our urgent care providers and operators.
You guys think it's fair to say that that there's some tailwinds, I believe, that are in place now that are favorable to telemedicine. And I think they range from reimbursement has been, just about promised by the federal government for most of these cases. The barriers to entry from a regulatory perspective have been broken down. The need for telemedicine is probably up 8 to 10x. It's serving a community health need. It's being demanded by our customers. It's consistent with the Affordable Care Act mandates of the future to reduce cost and increase customer service. So with all these tailwinds, just getting an extra, I don't know, breeze from everything related to the pandemic, it almost seems like you need to make a decision as an operator to be in the telemedicine business or to not be. I'm not sure if the window of opportunity to get into this space in the year from now will be there, because I think everybody is partnering with telehealth enablers or service providers to get something out there. Otherwise, these patients just aren't going to get some of the health care they need for these minor illnesses and injuries. But do you think that's a kind of a fair statement, that a decision to get into telehealth is something that needs to be made by operators pretty soon if they're going to do it or not?
Yeah, no, I completely agree with that. Jeannie earlier alluded to how to cut down the expenses, and the other side of it is how to possibly increase or sustain your revenue, right? And telemedicine, at least for now, is definitely looking like an important and a viable option for urgent care operators. We have had some really great discussions around this topic of telemedicine on our COVID listserv that has been circulating, and hopefully people who are listening are already on that listserv. So there's definitely some real enthusiasm around this, and it seems that it's the right time to seriously think about having this as an asset in your as a tool.
Great discussion. Hey, Carla, let's flip to the next slide. What I'd like to do on this slide, if it's okay, let me run through these questions. Just basically, it's around workflow in the past few weeks. So everybody has changed how they're practicing medicine in your clinics, if you're still open, in the past few weeks. So there's been mechanisms that people have put in place, to identify high-risk individuals or people under the suspicion for the virus, isolate them. How are they tested and dispositioned at the end of the day? Everything down to how we're cleaning our rooms. But I thought it would be good if I'd like to ask Jeannie from Physician One to kind of run through comprehensively what does your workflow look like, maybe by patient type. So I know telehealth is pretty straightforward, but what about folks that call and say, I'm not feeling well, I want to come into the clinic, or folks that just show up to your parking lot? How do you guys handle that workflow with the idea that, number one, we need to protect our employees, number two, we need to protect our patients from further being exposed to potentially other patients, and three, still be able to provide the care and triage necessary to get through this pandemic. So Jeannie, why don't you just run us through your workflow there?
Sure. So I will start with the patient that walks in. So patient walking in the street, off the street, decides they need to come into the urgent care. They're stopped at the front door before they can even walk in our waiting room. We have right now a massive poster-sized stop sign that's pasted on the door that says, "Stop. If you have any of these symptoms, we're going to ask you to go back to your car and register from your car." In many cases, we actually have a front desk person or one of our MAs manning the door so that they can explain to patients. That person is wearing a mask and some limited PPE, keeping their distance from the patient if they have to speak with the patient, and directing them what to do next. So in those cases, they're asked to go back to their car. We use a registration platform online already that's integrated with our EMR, and we've been able to leverage that platform to send a text message to the patient to give them a link so that they can register for a visit from their car. Our registrar that's in the site will call the patient then and provide the patient and obtain any further information they need and advise the patient, okay, we're essentially now using the car and the parking lot as our waiting room. And we're telling the patient, we'll be with you, you're next in line, or you're two patients in line, the provider will be giving you a call and discussing the case with you, and we may decide to bring you into the center, and if we decide not to, we'll see you in the car. So when the patient's actually, kind of put into their virtual room in our EMR while they're awaiting the provider's availability, and then the provider no longer sees the patient in their exam room. They actually see the patient through a telephone call at this point. And they'll do the intake all through the phone and make a decision whether or not this is a sick patient that needs to stay out or a well patient without any symptoms or risk, and they can be brought into the center. If they stay outside, our clinicians are donning their PPE and going to the car side and doing an evaluation of the car. They can do a limited physical exam. We bring a toolkit outside with us. The provider is the only person that has to wear the PPE because the medical assistant that goes out with them stays several feet away and acts as a buffer for the provider. It's a complete change in our process. Previously, so we can do a lot of that stuff outside. We'll keep the patient outside and never bring them back inside our center. We are preserving PPE. We're preserving the exposure to other patients that otherwise would have been in the center exposed to them, and we're preserving our staff as well, because we're really limiting the staff that's exposed to this potentially risky patient. And then, if the patient is determined to be safe to come inside, so this is maybe, an ankle sprain, and we've screened them and ensured that they don't really have risk, we're still taking precautions by, kind of whisking the patient away from the waiting room and rapidly bringing them into an exam room, limiting their exposure within the center in the hallway or the waiting area. And then, we'll go through a regular process with a patient that's brought in through the door. We've modified how the patient that's sick sometimes still does need to come into the center. And if they need to come into the center, we have a process in place by which we ensure that they're masked. We limit we have a designated sick room or rooms. If they're brought into the radiology suite, we have a process in place by which, the room is cleaned in a different manner than it was prior to the COVID outbreak. We even had in place early on, the rooms that the patient was in were shut down for a period of time before they were considered to be used again. We've been staying in very close contact with the DPH to provide us guidance on that. And as the regulations have changed, we've verified the change in our process with the DPH as well. So I think those are the major changes. We have a whole pathway to follow. And initially, this was kind of accepted by our staff with trepidation and, I don't know if I want to say, that people were really suspicious that this was a good way to practice. And now everybody is so grateful and thankful that we did that early on. And everybody's on board with the plan. They love it. They feel like, they've got this process down. It's efficient, it's quick, and it's saving, all of these resources.
And a person that is under suspicion for having the virus meets pretty strict criteria that needs to be obtained through some pretty specific questions. But those aren't often asked in an initial triage form or initial interaction with the patient. So when you ask for a patient, hey, why are you here to see us today kind of thing, how are you guys going about distinguishing, a runny nose from a true rule out COVID-19 patient? And were you having trouble, do you think, with some patients maybe not being quite as truthful to you because perhaps they thought they weren't going to get tested or they weren't going to be seen if they had true symptoms of COVID-19? Did you have any experience with that?
I'm so glad you asked that. Absolutely. So early on, we were following guidelines that I think UCA had put out, as well as the CDC that really were asking, with a sign at the front desk to identify patients to self-identify if they had symptoms or had a travel history. And we missed a lot of patients because exactly what you said, patients were either, minimizing their symptoms or afraid to identify themselves for fear that they were either going to be sent away or not properly treated. So we often found patients misidentifying themselves, and then we wouldn't find out that they were at risk until the provider started their questioning, which is why we eventually put this process in place that's just said you can't even come inside until we do the screening, and that screening is now being done by the provider on those telephone screenings.
Gotcha. So it sounds like just a complete revamping of your entire workflow, but resulted in you being able to care for just about everyone you would normally care for in a safe, effective manner, while still protecting the patients from further exposure if they're not sick, and also protecting your staff. I think you guys have developed an outstanding example of what may become sort of best practices in this kind of environment. So congratulations on that. Why don't we flip to the next slide, and let's talk about drilling down a little bit closer to our staff and our patients, some concerns that I think all of us are addressing. So Sean, let's start with you. How are you guys addressing staff concerns? You heard Jeannie speak a little bit about the staff being a little bit wary about new proposed protocols and taking care of sick people. Maybe not everyone was in full PPE to do it because of limited resources, but how are you addressing staff concerns? And is there a tempo or cadence of communication strategies you put out, or what are you doing in that regard?
Interestingly, we had just recently gone under UCA accreditation and passed that back in the end of last year. And one of the big things that we noticed that we weren't doing as much as we are now was connecting with our team, building a team that had connections with everyone at different levels, and meeting more, and having regular cadence of things like a morning huddle or what have you. So once this started, I instituted morning huddles every day of the week. For a few weeks now, we're going to every other day. Essentially, I go through what's going on, what we're hearing, talk about how our system is reacting to the situation, and then I just let everybody loose and have them ask their questions. Unfortunately, in this environment, and as part of a large system, I don't have all the answers, and nobody really does, but I think people really appreciate at least being heard. We've instituted a individual, we have different pillars that we look at as we're going through this, including our workforce pillar and our communications pillar and our patient flow pillars. And different people are in charge of those pillars, and they're the person for communications in charge of making sure that the staff has the answers to the questions that they need and they feel that they're being listened to. So I think that's made a big difference. It was something we started before this, but we kind of supercharged it as this happened. I think after a couple weeks of this, the questions have gone down to 1 or 2 a day, if any. And I feel like our staff and our team has really kind of gotten comfortable with where we're at.
Yeah, Jasmeet, anything to add to that around addressing staff concerns?
Yeah, communication. Like Sean and Jeannie said, it's all about communication, I believe. And luckily we have been blessed with some great staff members as well. So a couple of things that we are doing specifically for communication is the morning huddles. The huddles come out each week, and we make it a point that providers and non-provider staff, they all attend the huddles and make sure that they're up to date with the most recent information, be it about staffing issues, be it about equipment issues, be it about new PPE guidelines and whatnot. So that's one. The other thing that our chief medical officer does a phenomenal job of is that at the end of the workday, every day she sends out a summary of, hey, this has been what's been going on today at all our sites. These are how many patients we saw. These are the X number of tests we did. These are the new guidelines for PPE based on the discussions with the CMO and whatnot of the hospital system. and also based on the CDC guidelines and whatnot. So there's a huge chain of communication that we are continuing every single day, obviously while also keeping doors open for any questions that come along either from the providers or the non-provider staff. Is there anxiety? Absolutely. I think the level of anxiety has surprisingly gone down as compared to the level of the illness that is actually rising in the community. I personally felt that our staff was more anxious to begin with, and now has actually, has the anxiety level has gone down. Could completely be my perception. We are blessed because we're a healthcare system, so it's kind of a partial view of the world, but we are blessed with having an occupational medicine department. So if there are any issues with employees or people who are exposed or could be potentially exposed, we have a full department that can help us, take care of those employees, do the right thing, and make sure that we are following the proper protocols. But that is a huge help, and can make a lot of difference in the way the staff perceives whether we are caring for them or not.
And we're probably seeing staff anxiety related to the change in how we work, and those kind of things, and just a complete disruption to their normal workflow. But I think another component of that is the anxiety associated with folks' personal lives, because if you're not high risk yourself, you likely are related to someone who is, and most people live with other folks, and so the anxiety of working in an environment where you're highly likely to become exposed and then going home to your family. So I think when you wrap all that stuff together, I think folks are not feeling really great about what's going on, and maybe feeling a bit odd. And there's a great article that came out several days ago in the Harvard Business Review. I forgot the author's name, but he co-authored the book Death and Dying with Elizabeth Kubler-Ross. And basically he applied the model of understanding grief and grieving to what's going on now. And then in a sense, I think that's what all our staff are feeling, is a little bit of this sort of anxiety associated with this anticipatory grief of not knowing what the future holds. And that can be very disconcerting. So even pulling, I think it's perfectly appropriate and necessary to really alleviate the staff's concerns around what we're working hard on in terms of obtaining PPE and creating safe environments, and as a nation getting a handle on this. But I think we also have to address, their personal concerns and open up lines of communication that are, appropriately private, so folks can sort of get their own concerns addressed. And I think that's a great article to read. It's in Harvard Business Review, and it's a great model for what the country's kind of going through. And I think a lot of operators have expressed just what you guys did. What about high-risk providers, Jeannie? Have you guys had any providers that would fall into the CDC criteria of a high-risk individual? And what are we doing with those folks? Are we just like not having them see potential COVID-19 patients? Or are we moving them from the workplace, or what's going on with those folks?
So, we've been fortunate because we have alternate work available. In our case, we've, implemented a pretty robust telehealth platform during this time, and we've been able to shift the work in that direction for some of these high-risk folks. We certainly do have folks that fall into that category, and so, when in the case of providers, we can put them on the telehealth side. We even have a role for our medical assistants and front desk attendants in the telehealth platform. So in some cases, we've been able to shift people there. We have also offered leave for those folks, and with reassurance that their job is protected if they choose to accept that, or if that's what they prefer. So we've been able to accommodate that. But I know that, in many instances, particularly for smaller operators, this could pose a huge challenge in terms of You know, you have one provider for a given site, and if that provider's in a high risk category, you know, you're faced with things like, do I shut down my center because I don't have a provider to staff it?
Yeah, no, great points, great points. Listen, I think we're just about out of time. I'd love to open it up to the panel for any closing thoughts. And maybe Sean, you could represent the panel in this. And just from the UCA perspective, what would you like all our members to know and to really hang on to during this very difficult time, in terms of always knowing that the UCA is going to support our members and be a source for information, you know, in perpetuity. But what are some parting thoughts from the organization to our members, Sean?
So I think first is that UCA is here for you. The College of Urgent Care Medicine is here for you. It is really important that we don't diverge from what's being done nationally, locally, and regionally. So you need to check with the CDC, you need to check with your local health department, you need to check with your state health departments to make sure that you're all on the same page and that you're doing what you need to do. We have limited what we've provided and not created things outside of those organizations because we feel strongly that we should lead, but we should also follow. This is a national emergency. It's a little different than other things. It's important to understand that the very most likely situation that we should expect is that at some point this is going to peak and go away. Now it may come back, there may be other things, but we need to think about, what about then? What do we do when that happens? How do we get from here to there? We need to remember that there are still patients with UTIs and ankle sprains and strep throat, ear infections, and other things. And we need to be very careful not to push them off because we don't want to deal with, or we don't have the PPE or the appropriate stuff to deal with these COVID patients, because that's our bread and butter and that's what we do. We need to make sure that that we're doing what we need to do so that we don't come out of this on the other end where people don't feel like they need us. I don't think that's what anyone's trying to do, but we have to be very careful. You know, the number of patients seen each day at urgent care versus the number of COVID patients being seen nationally is still a small number of COVID versus our normal day-to-day patients. I know our numbers are down because people are sheltering in place or stay-at-home orders and what have you. But let's remember that we're a resource for the community, we're a resource for our patients, and that we still need to be there. And that UCA and the College of Urgent Care Medicine, along with the foundation, which are all kind of sister organizations, are here for you. And we're going to continue to be here for you. So reach out to us. There is that listserv. The listserv is excellent. It is not monitored in the sense that communication is not limited. So you have to be, you know, buyer beware of what you're hearing and what you're seeing. Check it out twice, but it allows people a free flow of communication in a way of talking between each other and coming to some answers to some of these problems. This is a very unique situation in our lifetimes. It probably hasn't been anything like this since the 1918 flu, which, you know, we had somewhere between 50 and 75 million people lost their lives then. We're not looking at this now, which is another bright spot. Not that, you know, not that any loss of life is ever a good thing, but we'll get through this. Let's work together and let's be the best we can. Rob?
Great, appreciate it, Sean. And Carla, you want to wrap it up here?
Sure. Thank you, everybody. Thank you to the panel. UCA appreciates the time you guys took to put this together. And then also anybody who attended, thank you. You know, as these are very unprecedented times for our country and the world, and we appreciate all that you as the providers, urgent care centers are doing out there to fight this virus. So thank you. Just wanted to also mention we do have 2 more webinars this week. Tomorrow we have Abbott is going to talk about their new point of care testing for COVID-19. So if you want to attend that, there's registration. There's a link right here on our page to where you can register for that. And then also on Thursday, the 2nd, we're going to do a webinar on adding telemedicine. Dr. Bill Lewis will be leading that one. You know, definitely make sure you go to our coronavirus resource page. That's where you can sign up for the listserv. And then we also have the 3 months of free membership to the College of Urgent Care Medicine if you are currently not a member. So that will conclude today's webinar. Again, thank you, everybody. Have a great afternoon.